All right, good morning, everyone. So we could please have a seat for the next presentation. I have the distinct pleasure, I'm Debbie Condrey, the CEO of the Sequoia Project. I have the distinct pleasure this morning of introducing Dr. Jen Layden. She's the Director of the Office of Public Health Data, Surveillance, and Technology. In this position, she's responsible for leading, coordinating, and executing a comprehensive public health data strategy and improving the availability and use of public health data to inform decision-making and action. A primary focus of Dr. Layden's role is to provide leadership for CDC's data modernization initiative and serve as the advisor to the CDC director. Dr. Layden is also the recipient of numerous honors and awards, including CDC's Charles C. Shepard Science Award. So do we have Dr. Layden? Yes, we do. Dr. Layden, thank you so much for joining us today, and we look forward to hearing your comments. Dr. Layden, thank you so much. Will we see Dr. Layden on the screen, or you guys come on up? Yeah, there she is. We just have our panelist, Dr. Layden, coming up on the stage, so we'll get started in just a second. Again, Dr. Layden, thank you so much for the comments and the information. We greatly appreciate it. So we'd like to have a bit of a fireside chat here without the fire around public health and some of the things that is happening in that space. And with us today, in addition to Dr. Layden, of course, is two our panel experts who we brought today to the stage. So I'm going to hand off to Nora Cox, who is the CEO of the Texas eHealth Alliance, and LeAnne Lovett-Floom, who is a clinician working in public health and emergency preparedness. And I will mention both of them are highly engaged with Sequoia work groups. So welcome to the stage. And I'd like to start with you all introducing yourselves with a little bit more of your bio and your background, and talk to us about your engagement with Sequoia so far. Start with Nora.
Okay, great. So hi, everybody. I'm Nora Cox. I'm the CEO of the Texas eHealth Alliance. That's my day job. We are a nonprofit advocacy association in the state of Texas working at the state capitol, basically to keep my legislature from ruining everything. Because my fellow Texans will know that all this fabulous federal stuff that we've been talking about today, the instinct of my legislature is to do the opposite. So I love my work. I also was working for the governor of Texas during Hurricane Katrina and Rita. I was in charge of healthcare in the Texas governor's office. So I became interested in emergency preparedness due to that work, and over the years have had the good fortune of getting to work on the origins of the Pulse Project with Lee Stevens and some other folks, which led me down a path of Marianne looking at me one day and saying, well, there's this work group, will you chair it? And I said, yes, Marianne, because that's what we say to Marianne, we say yes. So I am the co-chair of what is now the Public Health Work Group, working with Debbie to bring these universes together, right? And I'm super, super, super passionate about it, in case you can't tell, trying to get emergency preparedness, public health, Medicaid, and all those disparate parts to work together. So delighted to be here today, Debbie. Thank you very much for having me, and turn it over to LeAnne to introduce herself.
Good morning, everyone. I'm Dr. LeAnne Lovett-Floom. I've actually been in healthcare for almost 30 years and started in disaster preparedness back in the late 90s. I've worked from the states of Arkansas to Florida, Virginia, and now California. So amongst all of that, I've been involved in local, state, and federal response efforts and led teams in that, as well as preparedness efforts. Currently, I do work for a group of other individuals working with the Sequoia Project for interoperability, and became aware of them about, 3 years ago, Debbie? So my background is healthcare quality with emergency management and trauma nursing as well. So I'm happy to be here and delighted to talk about the work we've been doing with the Sequoia Project, interoperability, and the importance of public health and how it relates to disaster preparedness and our public health efforts.
Thank you both for being here. I do want to mention, too, they both mentioned our public health work group. And that work group was convened really for two purposes. And both of them have been tremendous members. Nora serves as a co-chair of the work group. It is part of the Interoperability Matters program that Sequoia runs. So just as Dr. Tripathi mentioned earlier that the ONC does more than the RCE, Sequoia does more than the RCE, way more than the RCE, and the Interoperability Matters program is one of those really important programs that Sequoia runs, and the Public Health Work Group has the pleasure of being a part of that. So our work group was brought together for two purposes, one being to sort of serve in a space for public health, to advocate for public health, to provide information to public health that may not be available in an aggregated format. So we have produced a couple of deliverables so far and are working on a policy interoperability roadmap for public health at the moment. But the primary purpose of our work group and the work that we do is we are a community of practice. So we bring experts together in a variety of areas in public health, emergency preparedness, Medicaid, and have discussions around frustrations or innovations or, what are you doing in your state or what's happening over here in this state? What kind of data and IT modernizations are you working on? So those are sort of our focus with that work group. So in following up with that, I have a question, and I think I'll start with Dr. Layden, which I don't have to look over there because she's right here, Dr. Layden first, and ask, given your experience, obviously your broad experience with data and IT modernization at the CDC, what do you think are the key data and IT modernization components that public health should focus on? In other words, how does public health prioritize where to start? It is an environment rich with opportunity. Where does public health start?
Yeah, so great question, and you're absolutely right. There's a huge amount of opportunity, and I think one of the challenges that I've seen is we do have an opportunity, especially with some resources that have been provided from the federal government. The resources are never sufficient. The bandwidth of folks, the time is never sufficient to do everything all at once. So we really need to be strategic and prioritize. One, to be able to get the biggest return on investment from the investments and direction of resources, but also to be able to show the impact. The type of change that's needed in the data landscape for public health is a transformative change. We have so many siloed systems, hundreds of systems across CEC. The same can be said at the state, local level. They're often very siloed, antiquated systems that are not capable and able to serve what is needed for this nation. When we talk about having real-time situational awareness and that real-time ability and capability to detect public health threats and to know what that state is of concerning trends that are of great public health significance, our systems are not set up to do that. I do believe we have an opportunity to really pivot and shift to be much more aligned with the health IT sector. But that requires us in public health, admittedly, to be very strategic and to prioritize our work. One of the things that we've done to help in that direction is to establish that public health data strategy to say, here's the highest priority areas that we're going to focus on in the next 2 years. Of the core data sources, we've put a particular emphasis on case and lab data. And both of those data sources are certainly data sources that originate, or at least parts of the data flow originate from healthcare sectors. So there's a great opportunity to align those systems to establish a more to establish a more efficient and lower burden and more productive data ecosystem to enable us all across public health to do our job. So I think really moving towards a strategic, focused approach to defining that future state and then prioritizing a couple of use cases. One, to be able to show the impact, to build that trust, to build the confidence that this type of transformative change can really serve the needs across public health and for the nation.
Wonderful. Thank you so much.
That's a great
Nora,
answer.
any comments there?
I think listening to Dr. Layden talk, a saying that came to my mind is about how they say generals are always fighting the last war and not the next war. So when I think about public health and I think about what we learned from COVID, I think one of the things public health needs to be mindful of is not to refight the COVID fights, and to be prioritizing those initiatives, not just that map to the federal frameworks and all of the great work that the CDC and others are doing, but building redundant, reusable systems that can be theoretically multi-purpose, not just interoperable, but used for multiple use cases. Because we're really moving out of this super siloed ecosystem, right? Where each public health department or each public health program has its little tranche of stuff. And I generally, think of those folks as the last tribes of the Amazon that have never met any other people. You try to touch their stuff and they poke at you with a stick and they try to get you away from their stuff. We have got to move to understanding that all of those pieces are interconnected. And I think when you are setting priorities and you're looking at where am I going to invest time and resources, investing in the things that map upwards to a reusable, repurposable strategy, sometimes will help priorities fall out in a more organized way. You might not want to rescue a system that's going to be obsolete in 12 months. But first you have to admit you have a problem. And sometimes that can be the hardest part.
Thank you.
And I can speak to that too. From a clinician standpoint, it's very frustrating, especially when you're dealing with, I don't want to say in the line of fire, but when you're actually in the moment trying to have patient throughput, trying to move patients during a disaster, during a public health crisis, or just in everyday healthcare, it's very problematic when you have 5 different systems you're having to put data into, they pull from each other, when you're trying to just move the patient through and get them in and out as timely as possible. That disaster really heightens that even more because you have all these other systems, or you don't have the systems in place that you need to pull the data to get that patient in and out the door as well. So from a clinician standpoint, I think we've been very reaction versus being proactive in our approach to creating systems. And I would like to see us, to echo what Nora said and Dr. Layden, see those more intertwined and have the right stakeholders on board.
Thank you. That's great. And Dr. Layden, what do you think, given the many priorities and strategies and resource constraints and so forth that public health is dealing with at the moment, especially not really coming out of the pandemic, still dealing with the pandemic, of course. What is the best way, and how do we work with, given the organizations like Sequoia and others that are really raising public health to be recognized, and thinking about what are the best ways to communicate with public health? I always think about public health as very, very local. And it starts very local and then builds up throughout the state and then spreads to the country. So what are some of the things that Sequoia and other organizations might do to facilitate the implementation of all of these data and IT modernization projects at the state and local level? How can Sequoia be helpful in other organizations as well? What's the best way to communicate there?
Yeah, so it's a great question, and it's a complicated question, and I'll throw a few things out there. One of the things that we have increasingly heard from our state, local, tribal, territorial partners at multiple levels, whether it's the state health official, the state epidemiologist, programmatic leads, is the ask for us at CDC to be much more prescriptive in nature in the data modernization space. And when we were faced with COVID, and at the start of COVID, I was actually still at the city level, health department level. A lot of significant funds came, and people were just doing whatever they needed to, plugging money where to salvage the crisis of the day or fix the system that they needed to. Now that we've, in some ways moved out of that crisis phase, people are recognizing every jurisdiction doesn't necessarily have the expertise or strategic leadership or bandwidth to say, how should I modernize the ecosystem? So they want us to be more prescriptive in prioritizing work, even the technical approaches to get us to that future state. There's always going to be variation in different needs at the local level, in state level compared to the federal level. But broadly, the ask for more strategic direction and kind of prescriptive guides, technical playbooks of how to modernize is something that we are hearing a greater signal. So I think there's a couple ways to do it. One is we're trying to we're working with our state and local partners, and as we stand up the implementation centers, that's going to be a way that we really strategically prioritize technical assistance. We look for early adopters to join TEFCA. We identify and rally around some strategic priority public health use cases to be able to show that impact. So I think being aware of the activities that are happening there, the strategic coordination that we're trying to do at CDC to promote the.
Oh no.
Dr. Layden, I think we lost your volume. I'm not sure what happened there. Not sure she can hear us either.
Time out.
Okay. Perhaps we can get Dr. Layden back in a second, but in the meantime, I will sort of twist the question a little bit for you, Nora, for you and LeAnne, and sort of talk about what are the things in terms of Sequoia, the public health work group, interoperability matters. What are the types of things that we should be looking at in order to facilitate public health's sort of upward mobility with data modernization and IT modernization? How can we be helpful?
You know, I'll start by shamelessly self-promoting the work of the work group, which is this idea of having public policy roadmaps and checklists and modernization structures, a superstructure. So if you are a public health leader and you are overwhelmed by all of the things, which is what I think it still feels like for all of us, right? There's a lot to keep track of. I noticed people taking pictures of Mickey's slides earlier because those were some very nice short little lists of all the things we have to keep track of and all the things we have to do. So something as simple as our work group, which is collaborative and represents a lot of stakeholders, putting forward a document that says, if you are in a leadership position or an implementation position on public health modernization at any level, these are all of the things that are in play. These are all the things you need to be thinking about, and here is a rough order that you can take them on in. I think people are grateful for informed direction. To Dr. Layden's point about stakeholders want them to be more prescriptive. So that's the, you know, we don't normally always say that about the federal government, that we want them to be more prescriptive, but without that prescriptiveness, everybody sort of flounders. Which direction do I turn? What direction do I do? And in what order do I do the things? So Sequoia's ability to be both broad and deep really has benefit here because we're able to capture all those different pieces, put them into a deliverable, and give it to somebody who may not have the background on all of it, but we can give them an organized way to sort of walk through it and think through it that I think can really be beneficial.
And I agree. Our work group is definitely focused on where the gaps lie and opportunities for increasing awareness and improvement, but also inclusion of people we would never think that were in our work group before. We've really expanded, and that's been fantastic. The other thing I would like to point out is we have short-term goals, which people can look at and say, okay, I can meet that. You don't have to look at the whole big picture staring you at the face and say, we're never going to get there. We have short-term and long-term goals that will help us get to where we want to get.
Right. So shameless plug for the Public Health Work Group. Once again, if you have interest in joining us, please reach out and let us know. We're happy to do that. So a final question. I think we only have a couple minutes left, but switching gears to TEFCA, obviously. So TEFCA does include a use case for public health, and as Dr. Layden so graciously mentioned, we have worked to include public health and have public health at the table, having conversations about TEFCA. The RCE has. And I'm wondering, what are your thoughts around TEFCA and public health and the benefits of TEFCA and public health considering joining TEFCA? Let's start with you, LeAnne, this time.
As someone who's been out in the field on various capacities, I think it is invaluable because I think reinventing the wheel every time, like I said, the patient comes in or you're trying to pull data really hinders any kind of patient flow, any kind of data later on, data mining for what you want to see in trends. So I think it's a benefit. I know there are some pitfalls. We need to look at security as well. That's a big deal right now for data breaches. But as a whole, and to sum it up lightly, I think that it'd be a benefit.
So number one, it's great that public health was an initial use case, so I don't want to hear it about public health not being included anymore. Everyone was included. But I think the more important point is TEFCA is not just a set of letters or acronyms. TEFCA is going to be a way of life for the entire ecosystem. And if we are successful with TEFCA, that is going to have ripple effects across the healthcare system in all sorts of places that we may not even be thinking about right now. So when I talk to public health folks about TEFCA, I don't want them to get caught up in, oh, my lawyers in my health department aren't going to like the fact that there's a common agreement. Too bad. There's a common agreement. This is something that Congress has asked to be done, short of a mandate, obviously, but still encouraging everybody to get on the same page. Public health now gets to be on the page. So see that as an asset instead of trying to find reasons to say no. I think TEFCA as a lifestyle, as a choice, not just a framework, has a lot of power for the public health ecosystem if they take advantage of it.
Thank you. Dr. Layden, can you hear us now? Great. Okay. We were finalizing our conversation around TEFCA and would be interested in your thoughts as well in the fact that TEFCA does include a public health use case, as you mentioned earlier. What are some of the benefits, do you think, of public health considering joining into TEFCA?
Yeah, I think there's numerous. You have so many point-to-point connections across public health and with healthcare. To be able to streamline and be more efficient, I think there's a great opportunity. Two, the potential to meet really many different use cases leveraging this common framework. I could see it really helping with the case data exchange, but not just case data exchange. You look at so many other use cases, whether it's lab data, the vital statistics, querying for additional patient information in the times of outbreaks. There's huge potential. Recognizing that we need to move from these siloed systems to a much more interconnected with healthcare, I think this framework allows us to get there. The ability to have that common agreement and that trusted framework, I think are huge benefits. The information blocking capabilities, aspects that are part of that, I think, very much are aligned with, important aspects from a public health perspective. And the efficiency that is gained, reducing the burden on the data senders, the data actors across the public health ecosystem. So great opportunity. We are looking at ways at CDC that we can help support and enable, especially jurisdictions that are eager to join early on and be part of those early priority use cases.
Wonderful, thank you. I think we've come to the end of our time since we have a big red negative number flashing at us up here,
kind of scared of
which is sort of jarring actually, but we appreciate Dr. Layden. We so appreciate your time today. Thank you so much for joining us, and we appreciate all the work you're doing at the CDC for public health, so thank you so much. LeAnne and Nora, again, my friends, thank you so much for joining today. Thank you all for listening and for participating, and I think we're headed to a break, so thank you so much.